Dr. Lowe is an assistant professor in surgical oncology here at Emory, and has been very actively involved in neoadjuvant studies, both locally and at the national level in the cooperative groups. And so interested to hear what you think, Dr. Lowe.
Great. Thanks, Dr. Lawson, for hosting. Thank you, AIM, for putting this together. And thank you to the patients for joining us on Saturday morning. And to the patients who are viewing this later, please feel free to reach out to any of us at any time to let us know your questions or thoughts. We'd be happy to discuss them with you. So, this is a broad topic with a fair amount of evidence, but probably not a sufficient amount of evidence for us to make any grand conclusions, not too dissimilarly from the discussion that Dr. Kuchikar gave us just a few minutes ago about triplet therapy. But let me set the stage a bit and define first what is neoadjuvant therapy. And in general, we define neoadjuvant therapy as that therapy which is given prior to surgery for a brief period of time, typically somewhere between 6 to 12 weeks, with the plan to proceed to surgery regardless of the receipt of the neoadjuvant therapy. And it would be the same operation we would perform if we had done the operation up front. And then, of course, patients would conventionally get medical therapy after surgery as though they hadn't gotten the therapy before surgery. So this is essentially a brief period of introduction to medical therapy prior to the operation we would plan on performing either way. And so I want to give a case example about the rationale for using therapy before surgery. This is courtesy of a colleague at MD Anderson Cancer Center in Houston. This is actually one of the original clinical trial patients for the BRAF/MEK inhibitor neoadjuvant clinical trial that sort of paved the way about discussing the rationale for neoadjuvant therapies. This is a patient that had melanoma on his trunk, and developed disease in the lymph node under the arm. This is a CAT scan image of their disease and a picture of the pathology from the biopsy of the disease. This patient received 8 weeks of medical therapy with a drug that targets BRAF and MEK. And at the time of surgery, or just pre-surgery, the CAT scan shows essentially no disease anymore. And the pathology at the time of surgery shows no viable tumor. Now, this is an excellent example of a response to medical therapy prior to surgery, but it really nicely illustrates the rationale behind therapy before surgery. This is a chart that highlights the progression of drug development over the past several decades. We'll start with the 70s, 80s, and 90s when Dr. Lawson was at the helm of the melanoma program here at Emory. He really had few choices to treat patients. And as time progresses, you can see the numerous additional therapies that have been added to the regimen and armamentarium of therapies for Dr. Kuchikar and Dr. Lawson. And all of these drugs, as Dr. Kuchikar alluded to, have made dramatic improvements in how well patients are doing from their melanoma. Now, the majority of the trials with these drugs were first performed in patients with stage 4 disease, but it quickly raised the question, well, if patients with stage 4 disease are doing so well, why not treat patients with stage 3 disease? However, after doing that, we found out that patients with stage 3 disease, and that is typically patients with melanoma confined to their lymph nodes, we found that outcomes aren't quite as good as they really could be, or as maybe that we hoped they would be. And that even after surgery and medical therapy, nearly half of patients' melanomas come back. And there aren't many options after they've received immunotherapy before surgery. So what can we do to decrease the risk that melanoma comes back after surgery and potentially help patients with melanoma live longer? Perhaps for patients with stage 3 disease, we can give medical therapy before and after. In other words, neoadjuvant and adjuvant therapy. So a bit about the rationale for neoadjuvant therapy. First, it might reduce the size of the tumor before surgery. Secondly, the individual response to the treatment. In other words, if your tumor shrinks or doesn't shrink might help guide what we give you medically after surgery. In other words, if you take a type of therapy and your tumor doesn't shrink, or if it grows, we may say, well, maybe perhaps we should switch therapies after surgery to help you reduce the risk that it comes back. Also, if we give you a medical therapy, in other words, a drug that treats your whole body, perhaps we can get a response to other parts of the body. And that highlights the idea that we might be able to treat other sites of disease that we can't see by examining you or by detection with a CAT scan or a PET scan. The thought being that surgery only treats a local area, as does radiation, but medical therapy, even if we can't see disease, might impact the development of disease elsewhere in the body. But of course, there's no free lunch. There are disadvantages to giving it up front. You could imagine that a patient's tumor might grow while they're on therapy before surgery, making surgery more difficult or impossible. There are treatment-related side effects, as Dr. Kuchikar alluded to, that may complicate the ability to undergo the operation or the complications from the operation. And then, of course, there's always a concern about the medications not working in the future if you're exposed to them early on in your treatment course. However, in general, we think that the benefits will likely outweigh the potential harms of neoadjuvant therapy. And that is because there will be a dramatic improvement in the ability of and survival with systemic therapy for stage 4 patients, and thus stage 3 patients will likely benefit as well. And that there's a rationale to give it before and after surgery instead of just after. So I'm going to briefly share with you the major clinical trials that have been published to date using neoadjuvant therapy. There are 6 major trials, and there are a heterogeneous group of trials, several of them using BRAF/MEK therapies, which you can see here as the DAB/TRAM groups, and then several trials using immunotherapy, highlighted here in these 4 trials. But what I do want to highlight to you is that all of these trials had very few patients in them. The number of patients ranged from 10 to 30 in each arm of the trial. In other words, I highlight that because of the point that these trials are small and provide a rationale to proceeding to bigger trials, but don't necessarily definitively answer the question as to whether or not all patients with stage 3 disease should get neoadjuvant therapy. So I want to highlight 2 trials. These are really the first 2 trials that were performed. And like I said, it really laid the groundwork for larger investigations in this setting. This is a trial out of MD Anderson that randomized patients in the 2 red boxes, one to upfront surgery and the other to medical therapy that targets the BRAF mutation. They got 8 weeks of therapy and went to surgery. And the outcomes were proven to be significantly better in the group getting the therapy before surgery instead of just after surgery. In a very similar trial, also performed at MD Anderson, patients were randomized to one of 2 types of immunotherapy here in the red boxes. Either two drugs, nivolumab and ipilimumab, or one drug alone, nivolumab. As expected, outcomes were similar between the groups, although the response rates were better in the dual therapy group. However, there were more side effects in patients getting both drugs, as expected, as was seen in the stage 4 setting. So I want to turn now to current enrolling trials at Emory as a highlight of how we've expanded the data that we have received from those smaller 6 clinical trials to how we might be able to use neoadjuvant clinical trials to answer bigger questions. And the first thoughtful question was really to ask, does providing therapy before surgery actually help patients live longer? In other words, is therapy before surgery actually better than therapy after surgery? And so this is a clinical trial that's being run through one of our cooperative groups, the SWOG network. I'm one of the trial leaders in this trial. And this is a clinical trial that, again, randomizes patients to get therapy before surgery and then patients to get therapy after surgery, really highlighting very specifically the question, is therapy before better than therapy just after? All patients get surgery, and then all patients get therapy after surgery, regardless of whether or not they got therapy before surgery. And so this is currently enrolling at Emory and around the world at over 700 sites across the world. This is a really landmark trial, and I think will provide a definitive answer as to whether or not all patients with therapy with stage 3 disease should get therapy before surgery. This trial is only about a quarter of the way enrolled, and so we're of course always looking for patients to participate in this to really give us a definitive answer about neoadjuvant therapy. Now, the other rationale for using neoadjuvant clinical trials is to test new drugs in this setting. That is to say, if we can provide patients with some amount of standard of care, which would be immunotherapy, but then add potentially a new drug to see if that new drug increases the ability of the immunotherapy to work. And so this is a trial that we have open here at Emory. I'm grateful for all the patients that we have enrolled in this trial to date. We're almost done enrolling in this. And this was a trial that tests a new drug, affectionately known as VX-15, in combination with standard of care immunotherapy like nivolumab or ipilimumab. And so these various combinations allow us to see what happens to the immune system and its ability to fight melanoma when it's combined with drugs that we currently use in the setting of stage 3 or stage 4 disease. And so again, this trial is currently enrolling as well to be able to answer a different question, that is, do new therapies improve what we already use in melanoma? So from the current trials, we can conclude that treatment given before surgery tends to result in really high rates of tumor shrinkage, which is of course good for surgery. And treatment before surgery is safe and doesn't actually impact patients' ability to undergo surgery or their safety during the surgery. And that based on small trials at busy melanoma centers with experience in treating melanoma, these trials have produced a very important and strong signal that therapy before surgery is actually quite effective. However, just as in the triplet therapy trials, more questions have been answered or have been posed because of these trials than answered. Some of them include what therapy should be given after surgery. In other words, if you go on neoadjuvant therapy and you have an incredible response, your tumor has completely gone away, do you even need therapy after surgery? Should the amount of tumor that shrinks guide how or if we treat you after surgery? And a more important or another important question is, how can we predict which patients are actually responding to neoadjuvant treatment? In other words, is there a good way to tell if the drugs are working before we take you to surgery? And all of these questions are currently being asked in ongoing clinical trials around the world. So the very binary or black and white question is neoadjuvant therapy ready for prime time? In other words, should all patients get neoadjuvant therapy? This is a yes or no question, but the answer is really both, yes and no. I want to say yes because I think we at Emory here, particularly I, feel very strongly that all patients with stage 3 disease, and this is disease that's not detected by sentinel lymph node biopsy, this is patients that present with large lymph nodes, should in fact get neoadjuvant therapy because of all the data that I told you about. However, there isn't quite enough data to actually say that all patients should get neoadjuvant therapy as standard of care. And therefore, I would posit that all patients with clinically detected stage 3 disease should get neoadjuvant therapy on a clinical trial. And as I mentioned, there are 2 ongoing clinical trials at Emory and 2 more in the pipeline. And so I really encourage you to speak to your physician, your surgeon, and your medical oncologist if you're in this setting of stage 3 melanoma to discuss what clinical trial options you have available to you. So with that, I'm happy to answer any questions as it pertains to stage 3 melanoma and neoadjuvant trials or surgery as it relates to melanoma in general.